Hi, I'm Danielle Leach. I am a patient advocate and a consultant to patient advocacy organizations interested in research advocacy and political advocacy as well. I am the former Chief of Government Relations and Advocacy for the National Brain Tumor Society and the co-chair emeritus for the Alliance for Childhood Cancer. And I'm happy to introduce Tamy Kim and tell us a little bit about yourself and what you do at the FDA.
Okay, sure. My name is Tamy Kim. I am the Director for Regulatory Affairs in the Oncology Center of Excellence at the FDA. Also hold a dual role in CDER's OOD as the Associate Director for Regulatory Affairs, which basically that office reviews the drug applications. As a part of my role, I work on various projects, not just project facilitate, but oversee policy, procedure, any complex regulatory issues that are coming from the sponsors, the divisions, as well as other centers. And that's it for me.
Terrific. Can you talk a little bit about the creation of Project Facilitate and the problem it aims to address in the healthcare landscape?
Sure. Project Facilitate was established in 2019, and it is really the brainchild, like many projects within the Oncology Center of Excellence, which is we abbreviate as the OCE. It was really the brainchild of Dr. Pazdur. And the reason why he wanted to start this is because he had conversations with leaders within the oncology field asking him how to apply for expanded access for an investigational oncology product. And he thought that if these major cancer centers and leaders don't know how to apply for expanded access, it's kind of a sad statement. So he wanted to streamline the process, pull the intake as well as the review of expanded access of oncology products into a centralized center, and it's a call center. So we started Project Facilitate in 2016 because of that. The other reason why he wanted to start this is to provide more equitable access to patients, because we knew based on the single patient IND requests that were coming in, that the single patient IND requests were coming from the major cancer centers, typically in Texas, New York, Massachusetts, as well as California, and less so in the Midwest states or the non-coastal states. So it's actually a part of our mission for Project Facilitate to provide more equitable access to patients. And this was at a time and he wanted to do this before 2019, even though it was established in 2019, but this was at a time where, equity wasn't really talked about. So he had some vision and we set it up in 2019.
That's wonderful to hear that the FDA was a pioneer in that work. Could you provide some insight into how does Project Facilitate work? What are the operational mechanics? And are there any specific success stories that can illustrate how it functions? And then perhaps maybe another story that illustrates some of the challenges that you guys face in your regular work.
So operationally, Project Facilitate is staffed by 2 FTEs, and that's Dr. Mitchell Chan as well as Dr. Cam Wilson. We are in the process of hiring a 3rd clinical analyst to intake single patient IND requests as well as review those requests and process them. So it operates in that manner in terms of intaking actual requests, but also providing guidance to oncologists and their healthcare team. And that could include oncology nurses as well as pharmacists. We interact with them, provide responses to any questions that they have. So that's one component. We also guide them through how to submit an actual expanded access request, what components they may need, such as filling out the 3926, getting a letter of authorization from a sponsor, which is what we call a drug company, and then ultimately how to submit that application. Once we review that application, and then we issue what is called either a may proceed letter, or we may issue on revocation a clinical hold letter, or we may get on phone with the healthcare provider um, if it's a complicated situation, because I think Dr. Meeker stated previously that FDA has more information that we review under the sponsor's IND commercial file that we might be aware of that might not be in the public domain. And on those occasions, we may get on the phone with the sponsor, the physician who may not be aware of the information, and either tell them that, this is not such a great idea, being nondescript because we're not able to divulge certain information. And they either need to modify the protocol or may go on clinical hold. So it can get a little bit difficult on certain cases. So in those situations, we'll either put the IND on hold, or the sponsor may choose to withdraw the single patient IND. As far as success stories, I probably can't go into many details about that because most of them are coming from patients or healthcare providers. But once in a while, we get a lot of I guess kudos for what we're doing, particularly with many of the healthcare providers. Sometimes they'll call in and they'll even write an email, but many times they'll call in and they just cannot believe that they're talking to a live person, being the government, and there's a phone number there, and it gets directed, may go to the Division of Drug Information at the FDA, but oftentimes it goes right to Project Facilitate and no transfer of lines. So we pick up the phone, and the facilitators, Mitch Chan as well as Cam Wilson, they're delightful people. They're clinical analysts that have a PharmD background, and they're just pleasant to be with and to speak to. So I think a lot of it has to do with personality for the facilitators and willingness to help, and they're frankly shocked because it's a government run center, and they're happy to interact with them. Some of the things that we haven't run across many issues where that could compromise the program. I would say that most of those issues had fallen into the bucket of technological issues, particularly when COVID hit, because we just had to figure out how to process and document the submissions coming in. It wasn't just Project Facilitate, but it was pretty much the whole agency. So most of the issues that we run into that may make the program a little bit difficult is mostly technology concerns.
Interesting. In what ways has Project Facilitate expanded since its inception, and what initiatives have been undertaken to promote and increase awareness among patients and providers?
Okay, so since its inception in 2019, Project Facilitate has expanded a lot. It actually started from pretty much a 1-person to 2-person program. I had come back from parental leave, and my right-hand person, Jessica Bamer, pretty much did the legwork on starting Project Facilitate with when we also hired Natasha Kormanik, who was the full-time FTE at that time. So they started Project Facilitate, but the facilitators were actually volunteers from the clinical review divisions. So it was based on one full-time FTE, another person, Jessica Bamer, who's my right-hand person, who's the regulatory person, and a bunch of volunteers. Subsequently, we were able to get 3 FTEs full-time that will intake expanded access requests and reviews of those requests. So those are the facilitators. But now, not only do we intake and review those requests, we also engage in outreach. We do a lot of outreach, or a fair number of outreach with academic centers, as well as oncology practices. We've done outreach with the VA, providing luncheons or brown bag luncheons, and what expanded access is, how to provide expanded access, what to do if your patient needs expanded access. And we also inform a lot of policy, not just within oncology expanded access, but for the agency. We've noticed as a team that Project Facilitate does get leaned on by the agency to a certain degree because it's a one-stop shop. So when we go to a meeting, it's pretty practical because we've got our everyday people who are staffing Project Facilitate, and we've got the policy regulatory people, meaning Mitch Chan, Cam Wilson, myself, and Jessica Bamer. So we're all on the call, and we can answer a question fairly quickly for the working groups on expanded access.
That's wonderful. How does Project Facilitate approach data collection, and what specific data informs program strategies and decisions?
Okay, so this is an interesting topic because I've been listening to the conversation throughout this meeting, and I know data collection is very important to this group. Another reason why Project Facilitate was started is initially when we started, we noticed that we didn't get a lot of end of treatment summaries that are actually required to be submitted, as well as annual reports for single patient INDs. So starting probably about a couple of years ago, we started to make a concerted effort to contact healthcare providers if they did not submit their annual reports or end of treatment summaries, and encourage them to submit these information. And if you noticed, or if anybody in this room has submitted a single patient IND and you've not submitted an annual report, you'll notice that you may be getting kind of automatic reminders to submit an annual report, followed up potentially by a request to submit an end of treatment summary, which could include the outcome of the patient, including adverse events. It started in 2019 where we knew these data were not being submitted, even though they're required to be submitted, to proactively asking for this information.
And how has that increased the numbers of people in submitting on time?
So I can attest for the past year or two, when we started making concerted efforts to proactively ask for this information, that we've been, upon sponsors not submitting annual reports, they will submit a withdrawal request, which basically gets the single patient IND off our books. But we also ask for outcomes data. So whereas previously we weren't getting much information in terms of outcomes data or annual reports or any information, we're now getting about 50% of a return when we're asking for these data.
That's a significant increase from almost.
It's a lot. It's a significant increase, and it's because there's a concerted effort of the facilitators and clinical analysts asking for this information.
That's wonderful to hear, especially with the concerns of the audience around data collection. How does Project Facilitate engage in collaborative efforts with other organizations or agencies to enhance expanded access?
So to collaborate with other organizations and agencies, we do a lot of presentations, a lot of educational outreach. And I wouldn't be surprised, and I know this to be true because we provide a lot of educational seminars to academic facilities, mostly and oncology community hospitals, mostly because our analysts are reaching out to those facilities and in a way saying, hey, we can present to your staff anytime you want. So we do provide those educational seminars. Occasionally, we will provide educational seminar to a patient advocacy group. We don't interact with them as much because with three full-time staff, it's actually a lot just to take in requests, answer questions from the healthcare providers, review the clinical submission, and process that submission and act on any follow-up. So that's actually a lot of work in itself. But occasionally we'll get a request from a patient advocacy group, and we will provide a presentation to them.
Considering its demonstrated effectiveness of Project Facilitate, do you foresee it expanding to other medical conditions its scope?
So that's a question that has been recurring ever since the inception of Project Facilitate. I have not heard of any plans or discussion within the agency to expand its scope. I think one of the reasons why it was started was, of course, Dr. Pazzer, who is pretty much the driving force between FDA oncology and has many different projects going on. He was a big supporter of forming a centralized staff and center for expanded access specifically for oncology products. So he had a passion for this. Not only that, he knew there were issues on the outside because he interacts regularly, as well as our staff with the outside cancer community. And then lastly, it may make sense in oncology compared to other disease areas or therapeutic areas because of the amount of volume, the review volume within oncology drug development. So we've heard the figure multiple times, and others can confirm this, but the drug development is within the drug development space for oncology is around 40%. So pretty much 40% of the drug development occurs in oncology. So we have 5 clinical review divisions reviewing solid tumors, malignant hematology conditions, and there's just so much work. Add that with single patient INDs coming in for both clinical reviewers as well as regulatory project managers. It just kind of makes sense to pull that work out from the clinical divisions and centralize it in one place. And ever since we did that, the feedback from the clinical reviewers as well as the regulatory project managers has been nothing but positive. We do consult with the clinical review divisions and reviewers on complicated cases, and they may actually reach out to us as well on complicated cases, on maybe something that they have come across their review that we may not know about. We've also started this past year reviewing our program or providing data for our program to the different individual clinical review divisions to help them understand what's going on with the program, what drugs and conditions are being requested single patient INDs for. So there's a lot more communication, but they do appreciate that we're handling the single patient IND requests and the review of them and the maintenance of them, just because there's a large volume of drug development and submissions coming to the oncology divisions.
It's really become a hub, so to speak. You had mentioned in our pre-discussion some of the data analysis and some of the improvements to the process. Can you talk about some of the data points that you've seen now that the program has been in it since its inception, like time to approval, geographic distributions of where the existing requests come from?
Sure. So time to approval, we pretty much cut down the response from submission of a single patient IND to granting a may proceed letter from about 4 to 5 days to less than 24 hours. And this is actually for both regular single patient INDs as well as emergency INDs. Demographics, we try to record as much as possible in terms of race and gender, ethnicity, as well as age categories for single patient INDs that we've gotten demographics for. And we are doing research in this area. So hopefully you'll be able to see it shortly. Most of the single patient INDs coming our way, the largest group is between the category of 18 years and 64 years, followed by greater than 64 years, followed by 2 to 11, and then less than 2.
Interesting.
Sorry to interrupt. I just wanted to let you know we're going to have to make a slight schedule change. So if we could start taking some audience questions as well.
Sure, no
Sure.
problem. Any questions?
Hi, great conversation. What are some of the urban myths that you're hearing from incoming calls?
Urban myths that we are hearing from incoming calls. Well, one of them, and I think that the record has been kind of being set straight progressively, is that I guess single patient IND review and access of an investigational drug is gonna take too long, and that's why healthcare providers who are very busy, be it the oncologist, the pharmacist, or the nurse. They're very busy, so they just don't even want to start the paperwork. But, you know, to their surprise, when they get a clinical analyst on the other line who's able to help them and kind of zero in on exactly what they need, they're pretty appreciative of it. Sometimes we get follow-up calls, you know, basically saying it wasn't as bad as they thought it was going to be. So that is an urban myth. Another myth is you do need to have a treatment plan, and that's built into the Form 3926. However, you may not need an actual protocol. We heard early on that it was taking physicians like upward to a week or more to get a protocol for a patient to put on expanded access to draft one. But if you have the necessary information in the 3926 treatment plan, and you have the necessary components, you don't necessarily need a full-scale protocol for that patient.
Any other questions?
Hi, I'm reading questions from our virtual audience. Someone asked, does Project Facilitate also review intermediate size patient population INDs/protocols and treatment INDs/protocols, or only single patient INDs? How does Project Facilitate interact with the division reviewers under which the IND for the product is reviewed?
Okay, so for intermediate and larger treatment INDs, Project Facilitate does not review those. However, we do get involved in these discussions because anytime a single patient IND comes in a larger volume, say greater than 10 or 100, we will present to the division, or starting to present to the division, in asking them, hey, do you guys want a larger intermediate or treatment IND protocol to come in for this? And we'll basically interact with the divisions to see, you know, whether they would want such a submission to be submitted. And when it is submitted, or if it is submitted, that would be reviewed by the clinical review divisions. Did I miss another part? Oh, the other part is we're interacting with the clinical review divisions more because we are presenting at their different clinical rounds for each specific individual review division on our data.
Hi, Diane Hoey. I'm a volunteer ALS advocate. And I know you said that you're not aware of any plans to expand this beyond the oncology division, but people in the ALS community would be very interested in something similar, especially with the Act for ALS grants out there. And it's kind of new to the neurology community. And so you get the same kind of, you get a situation where people are saying, I want to participate in this expanded access program, and neurologists not really understanding what to do. So if you could take it back and talk to the powers to be, people would be appreciative of that. Thank you.
I'll take it back. There's actually agency-wide expanded access working group, and we meet frequently. So I'll take that message back.